Hi, everyone.
Morning.
Good morning.
Good morning.
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 Hi.
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 Good morning.
Good morning.
I love hearing the diversity of accents when everybody says hello.
Yeah,
Morning.
we should actually make it a rule. So in a moment, everybody in their own language is going to say good morning. That'll give it a real European feeling, or make international, I guess.
Guten Morgen.
Egunon.
Goeiemorgen.
Morgen.
Bom dia.
Buen dia.
Goedemorgen.
Bonjour tout le monde.
Bonjour.
Supravat.
Buen dia.
Dobré ráno.
Keep going.
Goedemorgen.
Dobrý ránok.
Right.
And
Well,
Boris,
welcome
all the
everyone.
Welsh
I'm going to.
speakers.
Right, we've
Yeah,
got 10 minutes left.
Oh, we have. They told us it starts 10:15. No.
No, I was joking. After everybody saying good morning, that's what I meant, David.
Oh, I see. Sorry, I was too slow. Well, welcome everyone. It's wonderful to have all of you with us. Rob and I are delighted that it's not just the two of us. We see enough of each other. And so for those of you who I've not met yet, my name's David Grant, and the work that Rob and I are going to present today is work that we did whilst I was still chair of the Bristol Medical Simulation Centre, and with oversight of the Bristol Paediatric Simulation Point of Care Programme in the Children's Hospital. I have left those positions to move on, and so my current role is at the University of Bristol, where I program direct a master's in healthcare management, which actually, all truth be told, stemmed from the kind of work that Rob and I are going to describe, and trying to figure out how we take some of the principles we'll talk about into the wider healthcare management to try and help us optimize healthcare environments. And then, of course, I'm currently still the immediate past president of SESAM. Rob, do you want to just introduce yourself, please?
Yeah, it'll be a lot quicker than that because my resume is not quite as long. So I'm a paediatric doctor in training, a paediatric registrar in Bristol, based in the Southwest. I spent a year as the paediatric simulation fellow in Bristol working with David, which was fantastic. And at the moment, I'm delightfully not working because I had my first baby about 4 months ago. So I'm taking some time out, but I'm very pleased to join you here today.
Wonderful. Thank you, Rob. So just by way of just making sure that you're in the right workshop, and if I see some of you leaving, I won't take offense, nor will Rob. But basically, we're going to sort of hopefully today with you explore an understanding of the importance of delivering complex real-time, high-fidelity simulated systems testing. We're going to describe with you the prepared framework, which Rob, together with a colleague of mine, Dan Magnus, and Kirsty Brown, they were the three main developers. I was merely sort of in the background in all of their work, have developed this systematic approach. And so we're going to share that with you. And so also we're going to hopefully in the breakout rooms, get you to use this structured tool in real time. And hopefully what will happen is that you'll go away with some form of template. And we'd love to hear if you've used this workshop to implement some form of systems testing at your in your workplace. We'd love to hear more of that, particularly if you end up studying the impact and publishing on it. And so hopefully our aim is to get you to go away feeling confident that you can take this learning with you. During you don't have to worry, we will give you a PDF printout of the slides. Plus, Rob is going to share in the chat with you when we get to that point some of the resources that you could use to implement that, should you wish to use that. And then just lastly, a little bit of what's the word? Housekeeping things is just to say that please, if you have a question, if you pop that into the chat room, if Rob or I think it's something that actually we should just pause and discuss at that point, we'll ask you to unmute yourself and show us your screen if you're happy to do that, or your video, and get you to ask the question, and then we might even come out and just have a conversation, because it really, our aim is to make this workshop as interactive as possible. Are there any questions just before I move on, or anything that you would like clarified? Okay, I'll take that as a no. Although if your typing speed is as fast as my two-finger technique, the question might still be coming, but we'll leave that aside. Really it's about the sort of the structure again. So there's a little bit of theory where we're going to present the framework to you, then we're going to get you to use it. And then the idea of the last part of the workshop is where you hear from your peers, and we're going to ask that in each of your breakout groups, you identify a speaker or a person who's going to give the feedback to present your idea of what you've used the framework to work through, your systems testing that you've planned. So what that means is that when you're in your workout group, there's a short period where you pitch your different ideas of a system, and the group then agrees, so that we work through one example that hopefully will help you to go and finalize your own examples that you thought of. Okay, so as we said, both Rob and I come from the beautiful city of Bristol, where for the 3 days in a year that our sky looks like that, this morning it does, is that blue. That bridge has significant importance in this city because this is where most marriage proposals occur. And so we always hope that it goes well, because otherwise we don't want disappointment at that height. But yeah, we love the city, partly because it's small enough to enjoy. So just by way of starting, you should have no, I don't know, do we have hand raising within this, Danielle?
Yes, we do. Yes. So all participants
Okay.
can raise their hand.
Perfect. Thank you, Colette, for demonstrating. So what I would like you to do, so this is a British saying that I absolutely loved when I first came to the UK from South Africa. So not teaching someone how to, or your granny to suck eggs. And so just to elude some of that risk, or give Rob an idea, and an idea, I want you to raise your hand if you regularly do systems testing in your organization. And so hopefully I'll see how many hands are being raised. Thank you, Victoria. Yeah. Okay, fantastic. It looks like there's quite a fair number of you, and so therefore it's a high risk of teaching your grandmother to suck eggs. But so what I would like to do, though, it's really important, I'd love to learn from you guys as well. And so if there are elements that you think we should consider, or that you want to contribute, please do so, so that the group learns from all of our collective experiences. Let me just move that along.
So I'm
okay,
enjoying
Rob,
all.
I think that's over to you.
Yeah, thank you. So I'm enjoying all of the comments from people who said we do it, but not often enough, or we do it irregularly. And I think that's probably a good starting point. So let's just clarify what exactly we mean by systems test simulations. the primary purpose of the systems test simulation is to probe for weaknesses in your clinical systems, in your real day-to-day working environments. It's not to educate your learners. That's very much a secondary objective, but the main thrust of it is to better understand and look for weaknesses in your clinical organizations. And that's a really big difference. In other aspects, it's very similar to the rest of the simulation that you do, but I like to think of it as a bigger, meaner, hopefully more beneficial, but also riskier version of what you do day to day. So David, if you can click on. How is it different? Well, by definition, it can only be done in real clinical environments. You're outside the safe, familiar confines of your simulation centers. And as soon as you're outside those safe places, it's unpredictable. You're surrounded by real patients, real staff delivering real care, and large tests have a very real possibility of impacting real patient care with the harm associated with that. Because of their size, they're also usually complex to run, and you need a very large team to deliver it. So you're no longer in the safe space of you and perhaps your 2 or 3 usual sim collaborators. You will potentially need a faculty of 10, 15, 20 people on the day just to oversee and make sure it can all be delivered safely. And one of the other really important differences that I think people sometimes overlook is that you can usually only do it once. So most of the simulations that we design for our learners are improved on an iterative basis. So you think you have an idea what their learning needs are, you run the scenario, some bits work, you cut out the bits that don't, and it's better next time. But these are so big and so costly in terms of the time and resources and just the number of staff involved that if you do ever run it again, it's usually because you've identified a number of problems, you've come up with proposed solutions, you've implemented those solutions, and you're testing again whether it really has solved the problem that you think it has. So given how risky it is, David, if you click on to the next slide, why would you possibly do it? Well, here you can see we've got our very senior clinical team. We've got our slightly flustered looking but very experienced intensive care consultant at the centre. We've got a senior paediatric trainee. We've got a senior outreach nurse. We've got a porter, and then hiding away in the background, we've also got a radiographer. And we'll come on to exactly what happened with this scenario. So if we move on to the next slide, why would you do it? Well, simply there are very few other interventions that will generate as much value in identifying the real problems facing real clinical teams in your environment. And you bring together a really diverse team to solve those problems. So on the left, you can see the output from our neurosurgical emergency return to theatre scenario. We thought that we may have a problem in getting patients back to theatre overnight with raised intracranial pressure. And then on the right, we've got the team coming together to talk about what problems they've encountered and how you solve them. And unlike many other types of simulation that you will deliver, there are very real, very quantifiable benefits in terms of financial outcomes, reducing cost, reducing spend, improving patient outcomes that you just don't get from other sorts of simulation. And when you're trying to improve the reputation, trying to increase the impact of your simulation team, there is very little that can do as much for you as delivering good, effective, reliable systems test simulations. David.
Thank you, Rob. So just a few qualifying comments that I've just realized as I listened to Rob speak that we should just clarify. And that is that, so today in our workshop, we're going to try and get you to use this tool, and we're not going to go into great depth about the delivery of such events. And that the reason I stress that, because that's almost a separate workshop, meaning the design of these events that take much longer than a normal simulation scenario. These are often events that are planned. It takes more than 6 months to plan them to do well. It involves the entire patient care pathway, so it involves multiple departments, multiple professions, both in the designing and the delivery of it. In terms of preparing to deliver it, We'll talk a little bit about that today, but it is about making sure the organization remains safe to look after the clinical patients whilst we're testing the system using this simulated patient. And also, as Rob highlighted, one of the key things is this is not an exercise you want to do without your so-called experts or senior people in the organization involved, and also it has to involve everyone. One of my favorite stories that I tell is of an occasion when we were systems testing our sort of emergency response to a collapsed patient. And in our organization, because it's we're quite thrifty in terms of saving money, we have one defibrillator per floor in the children's hospital, unless you're in a high-risk area like a cardiac area or ED or ICU. And the reason for that is that having a arrhythmogenic cardiac arrest in children is relatively unusual. Anyway, long story short, we were trying to figure out how we make sure that in these arrest situations, the defibrillator gets there as quick as possible. And Lee, who's one of our portering staff in our organization, who was part of this scenario after listening to all the healthcare professionals go on and on about what we might do, just he's the only person I'll allow me to call me Dave, says to me, hey, Dave, what if when I run to these events, I just, because they come from a centralized portering office, I just pick up the defib on the way to the scenario. And everybody went, oh. And the point I'm trying to make is that the people who work in the system are the ones who know it best. They can think of solutions, and you need everybody, not just the healthcare professionals themselves. So really just underlying the importance of really involving everyone. And by the way, Lee is the biggest supporter of our simulation program, and we still buddies, he still works there. So really important to involve everyone in these systems testing. So what's really helped us, I think, as an organization to implement this program and for it to be accepted culturally within our organization is because we've, for a long time, had some guiding principles that underpin our sort of journey, I should say, towards organizational learning. And so one of the first things is to move the early part of the learning curve away from the patient as much as we can. We very much sign up to the ethos in our simulation events that it's a continued learning experience, meaning that in all of our simulation experiences, you will find senior clinicians, consultants, if you wish, band 7 matrons, all of our senior staff take part in the scenarios because we use them to educate and drive their learning or continue to drive their expertise. And then really the third part, which pertains to this workshop, is a desire or a constant thrive to proactively identify risks within our organizations before patients come to harm. And so this really is a departmental. To give you an example of what that means in practice, in my, where I work in pediatric intensive care, every first Tuesday of the month, we identify through our QI board a system that the staff, any member of staff feels isn't working as well as they'd like. We put that into a simulated scenario event or systems testing event. And we try and proactively look at that, which could be anything from our chest drain box isn't so organized correctly, we're not storing things in the right place. And it really does help us to continually try and improve the service we deliver. That said, which to this audience won't be any news, is that one of the key elements to this is that you must create a learning environment that is optimized. And by that I mean, we very much approach all of our sort of point of care or in situ simulations with a view of aligning our service delivery teams with our learning teams. Because we strongly believe that if you learn together as an interprofessional group within those teams, you come to insights which you could never come to as a uniprofessional group. We try and make sure that we create time to train, so it's learning by design rather than by accident, if you wish. And also the third part, which comes with all of these things, is a culture of psychological safety, where in fact you're expected to speak up and contribute your ideas and that will get you in more trouble if you don't than when you do. And so that is really sort of fundamental to implementing this kind of program successfully. The second part is an infrastructure that allows this. If you're going to do this successfully in your organization, you have to find a way to decentralize its delivery. And so that we talked about the pediatric simulation program, what we've done is we've aligned, you'll see these purple circles in the middle with each of our governance pillars. We've aligned an educational unit in these, in some cases, not departments, but groups of departments, if you like, who are tasked with delivering a curriculum, which you can see on the right side, and this is loosely. And what you'll see is, so apart from preparing the clinicians, this concept of continued professional development, the team deliberate practice, all of these things that we deliver systems improvement, not just in their department, but within the organization and with our healthcare partners, the 34 plus organizations in our region that help us look after children, are all part of this approach of systems improvements. Is the task of each of these educational units. And that allows us to sort of decentralize and have these events happen at a frequency that hopefully makes an impact and improvement to our patients. So, sorry, having a slide moment. So prior to Rob and Dan and Kirsty coming up with this wonderful system, which we're going to share, and I know I'm biased today, this is sort of what it looked like somewhere in a corridor. Hey, David, you'll see, because this is not Lee. Can we get a child to theatre for damage control surgery in 15 minutes, do you think? And I go, I don't know. And they say, well, how about we just run a sim to check this? And that's where it started. But to be honest, what happened every time we reinvented the wheel, and what concerned me is that we didn't have a standardized approach of doing this to help these events to be of a high quality on every occasion. And so the triggers for us now, just before we get to the tool itself, as I showed you in that slide, is either at departmental level, which I explained or described to you what happens in my intensive care unit, not mine, the intensive care unit where I work. The organizational level, so, and this is often proactive, so when new facilities are opened up, I'll show you an example in a moment of a cath lab, a new service when we were suddenly designated as a regional trauma service. Fortunately, we didn't just approach, it doesn't just happen on Monday. And so how we prepared for that. It's also a situation where people feel that our standard operating procedures need to change. So all of these things are proactively, as new SOPs are developed, they're often tested in this way. In some occasions, however, it's reactive. And this is where the governance pillars has identified that our practice was not to our own standards with regards to a particular event that we responded to. And they might approach the sim team then to say, well, can we test this in a simulated environment so that we can come up with ways so that we optimize that performance. And so patient care pathways, so for evaluation, quality improvement, some of you might have heard me speak before about how we completely redesigned our response, or both identification and response to a deteriorating patient, and the impact that that has had. We're now nearly 5 years in of having holding on to wood, no cardiac arrests within the children's hospital, outside of ICU or in the ED, whereas out of hospital cardiac arrest. And all of that has come unequivocally from this program that we're describing. And then at a regional level, again, you'll sort of hear us talk. So as a region, because we have an operational delivery network, we try and identify elements that the simulation team can help the region improve the care that we deliver. And so this is an example. I mentioned the cath lab. So this was a new hybrid cath lab. These are senior members of the cardiology staff. There's our little simulated patient, a very low technology simulated patient, just a patient that we needed to take through the system as they perform their normal sort of work to decide whether the setup of this room is correct. And in fact, in this occasion, we identified 4 pages long of things that the developer needed to change before we were happy to look after real patients in this system. And that, again, because we had the buy-in from management suite, that happened, and there was a delay in the go live of this facility because of the safety elements that were identified in simulation. Just a quick example again of a patient care pathway. So we deliver in our center, we deliver ECLS or ECMO, particularly to our post-cardiotomy or cardiac surgical program. And on this occasion, what often happens with these patients is that we need to do CT of their head, and they had just installed a new CT scanner in our hospital. And so in this simulation here, can anybody, you can unmute yourself and just speak. Can anybody see what the problem might be here? We're trying to do a CT of the head, by the way.
The patient is upside down.
Yeah. Yes, so we might be able to see to his toes, but we couldn't get his head in the donut. And the reason for that was because we try and minimize the exposure of the patient to the circuit. Our circuits are relatively short. And in fact, as you, I don't know if you can see my pointer here, but as the circuit's here, the machine couldn't actually get around the edge of the gantry so that we could have the patient the other way. And so this is our lead perfusionist for our ECMO service, our lead for ECMO services, our nurse lead, and the radiologist, and everybody else in the meeting. And so as Wool is scratching his stubbly beard there, he was saying, I wonder how we fix this. And so there was a whole discussion. So they said, well, what if we just add 50 centimeters, he said, to the circuit? I should be able to get around the gantry. And I kid you not, as they were talking about that, the ECMO call went out and the team ran. And as he prepared the circuit, he did that. So this is literally that same patient the following day, and the patient's head is in the CT scanner. And my point being that had we not put it through this process, that patient where we were scratching our heads would have been a real patient. And so don't imagine that you know the latent threats in your organization unless you physically take patients through this journey. There will always be latent threats that you're unsighted to. This is an example of trauma services I've already talked about. In the interest of time, I'm not going to say too much about this, apart from the fact that we ran numerous situations where we had trauma patients come into the organization. And you can see here, it looks atypical. That's in the middle of the simulation, the areas where we pause, where people have a conversation of a problem that we're trying to solve before the systems test goes on. There are many, and I know that many of you in the room running system tests might have a slightly different approach to this, but we often use the pause and perfect technique to solve problems before we move on to the next part of the patient's journey. And so, as you can see, they immerse the patient throughout the whole thing. In this situation, I was told reliably by the company that owns or provided us with this equipment that a CT scan of this young patient's head does not invalidate the warranty, which I was pleased to learn. That's the inside of a Sim Junior's head, by the way, if you were wondering. Anyway, Rob, do you want to just say a few words about this slide?
Yeah, so this looks quite exciting in the hazmat suits. This was a couple of years ago at a time when Ebola was a significant concern, where we decided we had to get our organization more prepared to deal with that. And that followed a slightly different pattern to normal, where we developed a donning and doffing protocol. We taught it to the learners, and then we went and ran a systems test with them, having just recently acquired that information to see whether our protocols were fit for purpose. Now, that recently became a lot more relevant in the times of COVID, because that all of our inpatient emergency calls had to be completely rewritten to allow for the fact that any arrested or unwell patient could be unwell with COVID, and we had to protect both them and the emergency team. So we've reinstated that protocol, we revised it heavily, and that helped us get up to speed with our new work environment a lot more quickly.
Yeah, and we're purposefully, in the interest of time, we're not going to talk about these too much. But Rob, I wanted you to just say, so this very busy slide, which just gives you an idea of some of the stages, is some of this neurosurgical testing or return to theatre, which if you could look at the top left-hand corner, this is Rob's favorite
a trademark pose.
photo pose at the top there. That's Rob in this scenario. Do you want to say a few words about that, Rob?
Yeah, certainly. So this was a really interesting scenario where several people had concerns that as a neurosurgical centre, we needed to be well prepped to deal with neurosurgical emergencies at any time. And so we ran a systems test to see whether or not we were able to effectively and efficiently stabilise a deteriorating patient on the ward, take them down several floors in the lift to our CT to identify a problem, and then up several floors to theatre in a timely fashion. And that again led to some really interesting discussions, but also we've talked about some of the benefits of these, some really low-hanging fruit. So we identified that nurses did not have an easy phone to hand at the bedside to flag up a deteriorating patient. They didn't have an easy place to prepare medications. And these are cheap, easily solved problems that you just don't know about until it happens for real, unless you do systems test scenarios.
Yeah, and I think this is an example that spawned from, we looked at our sort of benchmark that we set ourselves in terms of how long it takes us to get a patient with a potential re-bleed back to theatre. And we thought we could do better. And that really was what spawned this systems test. So the last one that I'm just going to share with you, I talked about this regional idea. I think if you work in a regional centre, one of the things that often causes a lot of discussion and concern is time-critical transfer, particularly of children. And the reason for that is that the centres that you're asking to transport the patient is often not a recognized transport service. And to say that this was a project that was 1.5 years long, where the SIM program, and you can see here, we took a Simbulance, as they called it, to their local area to try and, for part of the systems test, not put strains on their local resources. But effectively, we took teams from the local teams throughout their system, and together with them thinking about how we optimize the time so that we get the time to delivery to the transfer to the destination hospital much quicker. And so that was done in collaboration with our regional transport service. And so again, it wasn't about our organization, but it was about looking after our patients, trying to optimize their journey and times of transfer to our hospital. Okay, so enough talking about it. So Rob, do you want to just share with our colleagues the sort of what the prepared algorithm looks like?
Yeah, certainly. So I'm just going to upload it to, in fact, I've just uploaded it to you. I'm just going to upload it to the group at the same time. So this is what you'll be working through in the breakout rooms. We start with the P, which is the problem definition. What exactly is the issue or the potential threat or the new service that you're trying to test? And in particular, one of the key nuances is the problem you're trying to address based on a hypothetical risk, or is this a real adverse event that's happened in your organization? Because if so, you need to be even more careful than normal about how exactly you plan the scenario. Next, we have R, which is it right for simulation? And systems test is an incredibly powerful tool, but it's not necessarily always the best one. It's, as we've said, it's a risky tool if it's not done very carefully, and you might well be using a chainsaw to remove a splinter. And if everybody already knows the problem, why not just fix it? If it's lack of training, if it's lack of equipment, is there another educational intervention that's better? Such as, even if you're looking at small teams, is a sort of rapid cycle deliberate practice where you run the same scenario, the same smaller scenario multiple times with teaching in between, is that better for you? So E, establishing aims, and P for planning with teams really come together because you want to engage as many stakeholders as you possibly can to try and generate the maximum value from your scenario. And in particular, when we're establishing aims, we need to make sure that we've got key organizational goals. What are the organizational threats? but all of your individual learners will also, your individual candidates will also want to come away with meaningful learning and meaningful improvements in their practice. And so we ideally like to make sure that, as well as our organizational goals, we have aims for each staff group or each team who are taking part in the scenario. Now, the planning phase, as we've said, can take quite some time, and you want to involve as many people as possible. In my experience, the list of faculty that you need can't really be too long. For example, do you need a pharmacist if you're going to be using real drugs on real wards? Do you want to use expired stock to save money? Are you going to be using real drugs and potentially depleting important medications in a real clinical environment? And make sure that you just spread word of it far and wide. One concern that people sometimes have is that if too many people know about the scenario in advance, that it won't be effective. And that's not something that I've found in my experience with systems tests. People knowing about it does not really take, even if you know exactly what's going to happen in the scenario, doesn't take away from the realism when you start running a simulation of that size. Assurance of safety. This is, if I had to say one letter was the most important, I think it's probably this, the assurance of safety. So a large systems test poses significant risks to the candidates, to real patients in nearby areas, to visitors to the hospital and the organization as well. And so every single arm of hospital management, of governance, of improvement needs to be aware of the test happening. I had one horrifying discussion with a simulation faculty member from a hospital in Texas that shall remain anonymous, who said that their management board wanted them to run a systems test for an active shooter within the hospital, where one of the simulation team would dress up as a gunman and walk through the building on an unannounced basis. And if you want to get your simulation team shot, that's a good way of doing it, but not something that I'd recommend. On a lower level, we regularly find that it generates so much interest when you run a systems test that that you will have crowded corridors and people find it difficult to get around. So having one member of your simulation team whose only role is to monitor for the real impact to the rest of the hospital on the day, and having that person have the power to pause or even stop the scenario is a really useful thing. So moving on, rigorous design. This is again something that needs to be put together very carefully. Ideally, the scenario should be written by the simulation team, but with contributions from all others. And you may well go through several drafts to make sure you've gotten it correct. And it also needs to be realistic. It needs to represent the way that people really work in real environments, rather than the way that they hypothetically should work, or even sometimes the way they tell you they work. Effective debriefing. So debriefing, as we all know, is one of the most powerful part of simulation-based education, but you're now dealing with a much bigger group full of large professionals, large professional teams. And how do you debrief them? Bearing in mind that your main goal of this is to identify problems to the organization and come up with solutions. You can debrief everybody together, but finding a large space is challenging. You can also find a problem where only the most senior consultants end up talking to each other, and all of the valuable input from your nurses or your porters gets overlooked unless they're a particularly confident person. Or you can debrief people in small groups or professional groups, so the nurses together, the doctors together, but then you lose some of those really important interprofessional conversations. So my preferred way of doing it, not that it's always correct, is to debrief people together as a large group before then breaking off into smaller groups for more detail. And then finally, how are you going to disseminate that learning to the organization? So this is fantastic education for the people who've been involved, but when you identify threats, when you identify solutions, are you going to share those via posters, via formal teaching, via the various different arms of hospital governance? That is a very concise run through a model that in practice will be done over, perhaps, as David said, 6 months at a time. But is a useful framework just to break down all the different considerations when you're planning these large systems test scenarios.
Yeah, and thank you, Rob, for that whistle-stop tour. I would like to point out, if you look at the resources, there are more details on the PDF that elaborates a little bit on these points, but we're keen to get you guys working with it. Just a few points that I want to highlight. So when Rob talked about right for simulation, what that relates to is simulation the only way that you can do this? And the truth is, sometimes it's a hybrid approach or different components, or it's a staged approach. And so what the team does is it looks at whether we need to work with teams, as Rob described, with rapid deliberate cycles, sort of in terms of improving that before we actually test that in the system. Because what you don't want to do is for the team to go in with a problem that you know exists. So the systems testing might follow after that. One of the other techniques we use that some of you might be familiar with is the FRAM, F-R-A-M. I'll put it in the chat in a moment if you haven't seen that. And there's an entire community called the Framology community. And so it's it's a very, very useful tool, which Eric Anderson, in fact, I might put you onto the website. I'll put a link to the website there. And what it means is, it's a way, it's almost like going through a tabletop exercise, but with the specific functions that relates to each step of the process that it asks you to think about. So what are preconditions? What's the outputs? And so sometimes what happens is we use that technology before we run the systems testing, because we actually identify things that we know already by just sitting and talking about it as a multi-professional group. On some occasions, as Rob talked, we've run the systems testing and we think maybe there are elements that we didn't identify on the day. And so we might use FRAM as a secondary sort of approach before we sort of complete the systems redesign. So I wouldn't like you to think that, you know, the reason we say is it right for simulation is not just because it's simulation or not. It's often used in combination with another methodology that helps us optimize the impact of the simulation, because it is such a large scale exercise that takes a huge amount of resources to run. Okay. Any questions just before, and you could just type them in the chat or unmute yourself just before we move on.
So Soledad Armijo has asked whether we have a method to design the scenarios or exercises. I do have a template that I can share as well that we just use for writing on, but in practice, the design process varies so greatly depending on the exact nature of the systems test. We've done systems tests that happen outside on the roadside, if that's the real clinical environment that your retrieval team works in. Your faculty might be huge, it might be small. It all varies so much that it's difficult to have a completely standardized template, but I'll share what we do have. Yeah.
And I think what's helped us a lot, so as SESAM members, you'll all have access to IRIS, but we use IRIS, the IRIS system, which is an electronic design system. And what that allows us is to sort of to use the scenario states almost as states of the patient's patient care pathway. So you're not just, and often in those situations, what we're defining is not the patient physiology is almost the sort of subtext, if you like, or it's something for us to hang the elements on. But what it does allow you to do is very specifically make sure that you have the elements in the environment, or the environment set up in a way that you want to. So yes, I think that is a good way, or that's certainly the methodology, and I'd be interested to hear what others use, but we don't have a different one to our normal design. Sigrun asks, what are the most efficient method for disseminating learning, ensuring that the right people get the information and their actions pursuing? Well, it's a great point, Sigrun, because what happens at the end of the reason we involve the key people from the different departments are because and again, we should have mentioned this. So the latent threats identified gets reported on what in our hospitals called a DATEX system, so our incident reporting system. And in the incident reporting system, it gets treated as if it was a clinical patient, except the patient is called pediatric simulation, first name, last name, and not just Sim, because there are people in the UK with the surname Sim. So those are separate, that is a patient that it gets allocated to, but the staff who the incident is attributed to is the local department and the people who have to do. And what that means is it goes through their normal governance system to resolve that. And so it's reported. So there's a feedback loop, or the governance is within that we use the normal system that we use. And then I guess in short, that's what we do. And then there's a combination of things like patient safety message of the week, which gets sent, which is just an infographic because people don't read emails. That pops up in your email as you read it. So if you open your inbox, you see it. And then also through in all of those departments, because they all have clinical governance and QI sort of meetings within their department, it gets fed back as a key message within that. And then, of course, the most important thing as well is that in future simulations in those departments, this new learning is embedded as a learning objective. So it's a multi-pronged approach. And then the next question from Diego: how long did it take your team to convince the management team to value of this approach? That was actually, so we didn't start doing systems testing until our point of care program was well established. And interestingly, because we've got a long history, almost 10 years now, of reporting latent threats through our normal simulations when they run, we were able to show them data on the kind of the latent threats that we were identifying in the system, that they were there. And so this was a natural progression for them. It was a no-brainer. If you tell somebody I can reduce the lawsuits or the risk to our patients, it's not a very difficult conversation to have. So I think you shouldn't divorce it from your other simulation activities, even though it's slightly different.
Victoria's asked a popular question of how you train faculty to be system simulationists. Can I speak to that?
Of course you can, yes, please.
So I don't think there's a big distinction in our centre between normal simulationists and systems test simulationists. I think we recognise that when we run our big scenarios, it's going to involve the entire team, and that the most senior people, such as David, all the way down to the newest members of the sim team, who take on different roles. And actually, there's huge value in having all of those different people involved in the scenario. It's useful having the new simulation nurse who's mostly worked clinically and has great relationships there, while you also need your big names, the people with the most clinical credibility, with the most debriefing experience, to guide those really challenging debriefing sessions. But I'd only been doing simulation perhaps for sort of 9 months when I directed our neurosurgical return to theatre sim, but it was in conjunction with all the most senior people in our faculty, and it's very much a team effort. Other than the huge consideration of safety at every point, I don't think there's anything massively different in terms of the skills required.
Yeah, I think absolutely, Rob, but I think it is a graded approach. It's a little bit like, I guess, good old-fashioned apprenticeship learning, meaning we have a very active faculty development program that develops people in those different pods that I showed you. So that distributed approach of debriefing. It is true to say that if you don't have somebody who's confident in this debriefing style, it's very easy for our sort of trained simulation debriefers to use our normal debriefing technique, and suddenly you find yourself learning about sort of, managing raised intracranial hypertension. And actually, it is, a little bit like in some of the conversations that we had yesterday, where people talked about moving away from being the educator, but the facilitator. Because actually so that is what we focus on, is that we facilitate the problem solving in the learners, if you like, or amongst the learners. And so we use a technique very similar to the Pearls technique, except our tools that we use, meaning a sort of a structured debrief with different feedback tools. And one of those tools is peer-assisted learning that we use, which focuses on getting the learning from the team. And so I think the reason I'm highlighting that is that some of the techniques that we use in these debriefings are already taught to the faculty, which means that in the pre-brief, we're very clear and we reiterate, and as Rob said, always a senior faculty member until we find departments are happy to run that. So for example, the SIM team are not necessarily involved, meaning the centralized SIM team, in the systems testing that we do in PICU, because we've done it so frequently that we have senior faculty members within that group that does that. But it raises an important point. I mean, maybe it is something that we should look at, is to actually design a bespoke faculty development course that incorporates some of these principles that's taught almost in an ad hoc fashion to people before they run that. Then I'm keen, so apprenticeship, yeah. Then I think I'm just trying to, if I'm curious about the specific debriefing techniques that works well with systems testing. I don't know, Susan, did that, my last comment, answer that? So I think it's about creating, it's almost you're stuck between a reactions phase where people highlight the things that they struggled with, and it's combined with the reactions phase from the faculty. So there's apart from the debriefers, there's a whole host of documenters that documents timelines and various other elements that gets fed back almost as an objective observer for the group to reflect on rather than the faculty. Because quite often what happens is that the faculty, in these situations, the faculty members in some occasions specifically are not people that have expertise in any of these departments, which I think helps them to sort of do that. Right, so without further ado, if it's okay with everyone, we do want to get you into your breakout rooms. So what I would like to do is we're going to put you into the breakout rooms, and we're going to give you 20 minutes to agree on, so if you very quickly agree on, firstly, a spokesperson, and secondly, a system that you might take through this process where you just write it. So for example, where you're planning with teams, is writing down the teams that should be involved in the planning. So you're going to sort of almost create a planning document for you in terms of how you're going to design the scenario, or the systems testing scenario. Any questions about that process? And we're going to give you a 2-minute warning, just because one invokes panic in my view, is to just come back to us and report back. And then we're going to give each group spokesperson an opportunity to report back to the group with the opportunity for comment from the rest of the group. Okay, thank you very much. Danielle, if you could move us to the breakout rooms, please.
Yeah, that's fine. I'll open those now.
Thank you. Right.
Welcome back, everyone.
Okay, welcome. I'm just going to open my chat so I can see that. Yeah. Okay, so thank you very much. Between Rob and I, we were very impressed with the conversations that went on in the breakout rooms, and we just wanted to give you all an opportunity to share that with other colleagues who obviously weren't in the breakout rooms with you. So we're gonna give you sort of 3 minutes more or less, by the looks of the time that's left for each group, just to share the key points or learning. So first of all, the systems that they were going to test, and then some of the key learning points that they got from it as they've gone through the prepared framework. So if I can ask this speaker for group one to give us some their feedback, please.
Hi everyone, my name's Laura. I'm the spokesperson for group one. We very much enjoyed using the framework. I think the group would probably agree that it was the starting off that we found most challenging about using the framework and defining the problem that we wanted to interrogate, really. So we had a lot of chat about what kind of situation would be suitable to test, and we've settled on looking at the introduction of a new protocol for major hemorrhage, because that's quite a complex, time-critical issue that involves a lot of people. So we thought that would be a good one to look at. In terms of defining a problem specifically, we found that particularly difficult, and actually it was the unknown risk that we were finding it difficult to define. So we've decided that our problem was identifying the unknown unknowns in this situation, rather than ones that we'd already identified. So having spent most of our time doing that, we then moved on to deciding whether it was right for SIM, which we did all agree that it was. Yeah, we felt that it was appropriate. Establishing aims, we went on to following on from wanting to identify those unknown unknowns. We said that the primary function of this exercise would be to test the new function of the pathway rather than testing knowledge and things like that, with a particular focus on human factors and specifically the interactions between different teams, and also this being a time critical situation, looking at identifying any delays within the system. So those were our two main aims that we came up with for that. Moving on, in terms of the planning, who was going to be involved, we've come up with a long list of teams, which in a sort of theatre, mostly focused on a theatre type environment, although we recognise that this is a system that would be used in multiple different areas of the hospital, so potentially ED, ICU, labour ward, that kind of thing. But focusing on theatres, we identified that anaesthetics and ODPs would be important to involve, the surgeon, haematology, blood bank, lab technicians, porters, nurses, also site managers, and switchboard, which is a particular, that was a very insightful choice, because I don't think many of us would have picked up on that. That is actually as far as we got through the framework. We felt it was quite a complex problem to work through in 10 minutes, but yeah, so that's where we got to.
Okay, thank you very much. I think, Laura, what you and your group identified, which I think would mirror with our experience, is the fact that actually the problem definition of what it is that we specifically want to look at is often the bit that takes the longest. And it's the most useful thing because it gets people's mind clear about what is it that we actually want to do, which is why, not surprisingly, it's the first part of that cycle. So thank you very much. Can I ask group three sorry, apologies, group two for their spokesperson to give us some feedback?
Everybody's quiet, and I don't know what group I was in, David. So because it's 3:30 in the morning here, so I'm not sure if we were.
I am from group 2. Okay, I'm not an English native. No, it's okay. So it was interesting because we don't have have the discussion in P, the time to prepare. The P was the objective was Mitchell that proposed the time to prepare emergency C-section. So it was really nice to everybody agreed. So the P is that the time to prepare the emergency C-section, and we think it's the best way to the right for simulation, the best way to test it. And the aims were it was difficult to do learning objectives here, because maybe it's to test the pathway to just the moment you decide is an emergency C-section, to get the patient to the OR and do the C-section and take the baby, like Mikhail said. And we just stopped here because we couldn't planning with the teams, and we just talked about the learning objectives, and we stopped here. So I don't know if someone from group 2 wants to help to add some information, please. Catherine or Katie,
yes.
or Michelle?
Michelle, yes.
Michelle?
Usually we have this problem actually, especially at night when we have an emergency cesarean section. To get the baby out within 10 minutes, for example, we need specifically to have the logistics, the anesthesia, the obstetrician available, and the pediatrician, especially if we have a fetal distress condition. And we need all this team to be available within 10-15 minutes. And we had this problem of getting the patient to the OR, which is on a different floor from the delivery suite. So this was happening actually. And we had also the problem if the chief resident is allowed to start the cesarean section, for example, prior to the presence of the attending physician. And this was a dilemma for us, and we need to talk about it and have simulation, for example, inside or in hospital, and prepare this and manage the condition. This was the aim.
Yeah. As a pediatrician, that sounds like a wonderful aim to me. So I hope you found it helpful. And what strikes me is that actually many of you got stuck in the first phases of this planning. And partly, I think what you described in your group, Daniela, is the fact that actually, if you don't have those professionals from those departments represented, in the multi-professional group of them, actually this exercise becomes much more difficult.
Yeah.
And so I guess for me, as I listen to you talk, that's one of the key things that I remind myself. So thank you for sharing that. Do we have group 3? And have we figured out which group Susan was in?
I am representing group 3 and Susan was not with us. So
okay, good. We'll figure it out by the end.
I don't know if it was 4 groups, then she was definitely in group number 4. All right. Okay. So we actually did it very fast, but we managed to complete the chart, obviously not fully finished. We did identify as a problem, one current problem of one of our colleagues from the group, that is the length of time. So one problem is the rapidness to respond to a postpartum hemorrhage in regards to treatment. So from the time of diagnosis until the time of treatment. So that is our problem. The right for simulation, it's definitely consistent with using simulation in the real environment. We need, obviously, we're going to be using a high fidelity mannequin, but we definitely need to do that in the real environment so that we can see the real timings from transporting blood products, transporting medication, transporting patient, etc. So we did consider that to be very appropriate. In regards to establishing aims, our aims is to, it is identified as a problem. I don't know, but it's been identified as a problem. Hence, one aim is improving communication between the different departments, expedite drug administration and blood product administration. And then we wanted to use the first simulation as a benchmark to measure the real time from diagnosis to treatment so that then we could set a target So that would be one of our aims. So it would be to do it within a specific span of time, being realistic, obviously. When planning with the teams, we just defined which one would be the members that we would need to get involved, which would be midwives, obstetricians, porters, lab staff, anesthesiologists, pharmacy staff, and if there is safety patient representative as well. Assuming that there are experts in debriefing and simulation methodology. If there are not, then we would add on a simulation expert there. In regards to assurance of safety, we would be using high fidelity mannequins, so there is no risk for patients. We would be using prepared simulated products, so we would not be using real blood products. And then about psychological safety, we would be ensuring or reassuring everyone that this is about improving our current policies and procedures and not about evaluating any performance. Rigorous design. So obviously we don't have time to design this simulation session or activity, but basically it would be, we would prepare a postpartum hemorrhage and activation protocol with as a surprise, obviously without the current members knowing about it. We would be working for improving communication between departments, and as I mentioned before, about improving the preparation of the blood products, or improving, no, speeding up. And then effective debriefing, again, we don't have time to do a debriefing questionnaire, but reflection about current processes, procedures, communication, and probably equipments, because maybe there is something in regards to equipments or physical barriers that impede the fact that we administer rapidly this treatment. And then how would we disseminate this learning? So that would probably lead us to review our current policies and procedures, probably to add new policies and procedures or protocols. And then we were just thinking about implementing sim courses to use the new policies and procedures, or well, the new ones or the review ones. So just to make sure everyone is aware about the new protocols and the new ways of communication. So that's what we did. I don't know if anyone want to jump in, just in case I missed something.
Well, that was a very comprehensive summary, and I am mindful of the time, so I'm going to probably cut that short. I just want to highlight one thing from what you said that stood out to me. Don't forget about the risks that you introduce with your simulation, using simulated blood products, and also the fact of that you're drawing resources from the organization's normal response team. And so, for example, when we have these, if it's going to involve our emergency response team, in fact, we have a parallel team that's a non-clinical team. And one of the things that means is you have to make sure that your switchboard team are online so that they know who they're bleeping, right? They don't want to bleep the wrong team for the wrong thing. So there are lots of risks that the event itself introduces.
Indeed. Yeah.
And so you just need to think about those as well. But thank you very much for that comprehensive summary. Group 4,
Hi,
did you have a summary person?
Yep, it's me. Hi, Connie. I'm sorry, not turning on the video because the Zoom might crash. So we talked about the problem is to transfer a COVID-19 positive client from a mental hospital, a standalone mental hospital inpatient unit, to an acute hospital in accordance with infection control guidelines. So that's the problem, well, we agreed on, and we all think it's right for simulation because it's first of all, fortunately, it hasn't happened in my unit before, but it's obviously a very imminent risk. It could happen, and because we think that it involves a lot of teams. For example, the transfer servers, 2 different hospitals, and so it's good to check out whether all these teams actually work up, and whether the logistics and the protocols that we've planned actually work in real life. And then we did say we need to sit down and have a tabletop exercise to see whether we directly proceed to simulation, or if we work out all the fine details before we go on to a simulation. And established aims as well, as I said, a system check to see whether we could transfer patients safely from one unit to another, and mindful of the infection controlled issues. And when we were doing planning for teams, Robert jumped in to reminded us that because it involves two standalone hospitals, we need to talk to quite a lot of people. So the psychiatric unit staff, including medical staff, nursing staff, admin staff, the transfer unit staff, whether we have or not a specified team for transferring COVID clients, and then the receiving hospital staff, that's from the admin people down to the maybe the A&E, the casualty department staff, and maybe the ICU staff. And also we need to make sure the hospitals know that this is an exercise, and then what you mentioned, that we're not drawing people from the regular services. So we got to safety issues, and so besides the infection control thing, and the threat to the standardized patient order mannequin, we talked about the psychological safety, for all the staff and units involved. And I think that's as far as we got, because we couldn't get to the rigorous design part because of the time issue. So yeah, that's it for us. And any comments?
Thank you very much. I think you've all done a fantastic job in a very short time. If I'm correct, I think that we still have team 5 and 6 left to report. Is that correct?
Yes, that's right, David.
Okay, so I apologize. This is really unfair. I should have started. Next time, Rob will get me to time better. I wondered if I could just ask team 5 and 6, rather than just explaining your entire thing, just some of the key things or reflections of going through the process that you want to share with a group that you struggled with or that you thought helped in particularly.
So I'll go first about team 5. So we were talking about trauma, major trauma exercise, focusing on team interactions, like multidisciplinary team interactions, assuming that the technical capabilities are already there. So few things that were really helpful was that we need to draft the patient journey to fixate what the problem exactly is. In terms of aims, like we need to involve the multiple teams, like the IT systems, the portering systems, and everybody. And then tabletop exercise was one major thing that we discussed, that within the smaller teams, we can have tabletop exercises to determine what the micro aims could be before going on to a big, like massive service exercise. And we said that there are so many teams, so stop and go kind of exercise would be better, like in smaller sections. And we also said, like, they are all participants rather than candidates. So to think in that manner. And few other things were measurement. So one of the things to measure the success of that was how the team members feel. But at the same time, there were other measures suggested, like time to CT scan, time to theater. So there were some measures as well we need to focus for assurance of safety. And finally, about the R, we said that how can we include patient's voice to determine the success as well. So I think that was in just
some really important points there, Rashid. Thank you so much. The things that I just picked up there, the one is that you were saying about skills. Sometimes what happens is you identify a skills need during the scenario or something that needs to be improved. And actually what we make clear is that we will have a follow-up or the contract with the participants. I like your terminology, because in the briefing, we make it clear to them that they are helping us and the organization optimize things rather than being learners. But that does mean if a learning need comes up, you have to, in your contract, agree that you will have a subsequent simulation that will focus on that developmental need. And it's really important that it's clear to the learner. Otherwise, it feels a bit like their educational need isn't met during that, and educational needs will come up. So I think you raise a really important point. Thank you very much. Group 6, have you got your spokesperson just want to summarize the key reflections for us, please?
Sure, we figured out I was finally group 6. So it was Katja's problem. you know, it was Katja's problem that we looked with that was like patients presenting with back pain to the emergency department. They were developing clinical pathways. The problem that they're trying to solve is that they were missing acute diagnosis or, you know, emergent things. We talked about like the different things. It was really helpful, like I said, to have Robert jump in because, you know, him coming back to talk about really defining the problem helped us think about, oh, later on in the steps when we talked about who needs to be involved, like, oh, we should talk about getting the diagnostic testing people. So to your point about, you need the operators and who else has to be. So it really helps you focus in on the future steps. If you take that time to really delve into that problem, I think was the kind of aha moment for me. And then it was really nice to talk about what other ways could you do it? Does this really be systems testing? Could you do it through virtual reality or retro projection, which I got to check out. Thank you, Soledad. Kind of like going through that whole process of the prepared system. So I think that tool is really great to walk you through that step by step. We talked about the learning objectives and stuff, and I don't know that you want us to go into specific detail. I think more of the learning was how that defining the problem really helps you with everything else. And if you don't do that well, you're going to miss things later on.
Absolutely, Susan. Thank you very much. Some really interesting points. So I've just seen in the comments here, would have been interesting if someone had a project that stopped after deciding some wasn't appropriate. I think that's a question for the group. Has anyone experienced that?
I'll just jump in, David. The reason I put that in is I think as simulation people, unfortunately, because we've got these hammers, things start to look like nails. And I think it's very good to sometimes get a little check in and say, you know what, it's not a nail. Go away with your hammer. We need to solve this a different way. And so I think we should recognize our own biases, that we try and somehow make it sim appropriate when sometimes it isn't. Yeah.
Interestingly, that is such an important point, Victoria, because I think for us in our organization, part of the reason we came up with this rubric is that's sent out to people who are asking us for this now. And so actually we have become much better at being the gatekeepers and saying, because that problem definition part helps them tell us exactly what they want, which then we can go, actually, you could do this in another way. So yeah, no, I think it's such an important point. Okay, well, I want to thank each and every one of you for your contributions. I have learned as much as I hope that you have from your colleagues. And as always, it's a delight spending time talking about the things that we love. And so I think, speaking on behalf of myself and Rob, this is certainly a passion of ours, and I truly believe this has helped me and my organization look after patients better. If there is anything else that you would like to ask or help or just advice in terms of starting a program such as this in your own organization, our email addresses are there. We would love to help you do this in your organization and learn the outcomes from that. So thank you so much for sharing your precious time with us.
Thank you. Thank you.
Thank you
Thank
very
you.
much.
Thanks, guys.
Thanks, guys.
Thanks. Thank you.